Muted right now. You are screen sharing.
Right now.
Oh, but when you're
When I
opening
go
it up, it's not.
into presenter mode, it doesn't. Maybe I have to.
Sharing is paused. Share windows to the front. I don't know what the apples do. Is there like an active window that? Other options. Do you need the presenter?
It was working before.
Yeah, I had trouble with that one time too.
Maybe I'll just do my desktop. I'll just share it. You flipped it.
Oh yeah.
Oh,
yeah.
Oh, but now, say, how'd you flip it?
Uh,
What'd you do?
At the top left, there's a swap displays. You might have to exit it. Oh, hold on, let me go up to the right. Yeah, here you go.
Okay, there we go.
And then if you want to point to it, you just go like off to the screen on the right. So that screen like is that.
Oh, gotcha.
When you bring it mouse to the left, you're here. When you go to the right, you're over here.
Gotcha. Okay. Cool. Okay. Hello, everyone. I'm Kevin. I'm one of the first year Pharmacotherapy fellows. I'm going to be talking about COPD, inhaled, and other pharmacotherapy. So the objectives of this lecture is to kind of discuss the management of COPD in stable patients. I'm not going to be talking about patients who are in acute exacerbation. I'm talking about some of the pharmacological and also non-pharmacological therapies. Sort of discussing the goals and the aims of the Global Initiative of Chronic Obstructive Lung Disease, and also just doing some literature review. I unfortunately don't have any relevant disclosures. So COPD, we all know it's a persistent airflow limitation due to airway or alveolar abnormalities and also inflammation. It is now considered the third leading cause of death. In 2019, 3.2 million deaths occurred worldwide according to the WHO. And just FYI, COVID had 4.2 million deaths. So the number one biggest risk factor is smoking. Other risk factors are including genetics, so patients who have alpha-1 trypsin deficiency, patients who have occupational exposures if they work in certain environments, and also patients who live in high pollution areas. But the good news is that since 1999, COPD prevalence has decreased about 1.5% every year, which is good. And then the age standardized deaths have drastically reduced for men since 1999. For women, it stayed about pretty much the same. But women didn't have that high death rates with COPD in the first place. So once the diagnosis of COPD is made based on spirometry and clinical diagnosis, you consider pharmacological and non-pharmacological therapies. So the non-pharmacological therapies include smoking cessation, supplemental oxygen if they require it, and encouraging exercise, keeping a normal BMI, diet. Does anybody know why I highlighted smoking cessation and supplemental oxygen as sort of the two more important ones? Yeah, those are the only two things that have shown for improving mortality in COPD. And the reason why I bring up keeping a normal BMI, a lot of patients who are either too skinny or usually if they're too skinny, if their BMI is low, they actually get a higher score on the BOD index. Other therapies at the time of COPD diagnosis, you should think about vaccinations. A lot of these patients are high risk for developing very severe influenza, pneumonia vaccines. So we recommend those at the time of diagnosis. And then of course the COVID vaccine. Be the guy on the right, not the one on the left. So the BOAT index, it predicts your 4-year mortality and morbidity from COPD. It has 4 criteria that it looks at. So it looks at your FEV1 after bronchodilators. It looks at your 6-minute walk distance. It looks at your MMRC dyspnea scale, which is a sort of like a self-reported how they feel, how far they can walk type of things, and then their BMI. And this is just from up to date. Kind of just, you can calculate it. So as I said, if you actually have a lower BMI, less than 21, you actually get a 1 point for that. Probably the only place you'll ever get a point for low BMI. But the BOAT index, if you have anywhere from 0 to 2, you have a 80% survival at 4 years. If you have a BOAT index 3 to 4, it drops to 67%. 5 to 6, similar is at 57%. And then if you're over 7 to 10, then you're very low at 18% at 4 years. And this is just sort of what I'm sure everyone's seen this, the MMRC dyspnea scale and the CAT scale. Usually the MMRC is kind of, you give it to the patient and they kind of fill it out for you. And the CAT scale is, like you can do that in the office too. But. So the Global Initiative of Obstructive Lung Disease, they recommend the management of COPD based on the patient's symptoms, so what they self-report, and then what the number of exacerbations they have in the past 1 year. So FEV1 is not used to in sort of categorize patients in the GOLD assessment, but it's used for to stage them. So their goals and the aims of the Global Initiative of Obstructive Lung Disease, they aim to improve symptoms, they aim to decrease exacerbations, improve quality of life, and start pharmacological therapy based on their initial assessment, based on their symptoms and their risk of exacerbations. But not every patient will fit into each box of the GOLD classification. So we'll start with a case. This is actually my clinic patient I saw early this month. So he's 72 years old. He has a 50-pack year smoking history, HFpEF, COPD on 4 liters. The reason I say this is because he was never formally diagnosed. He just kind of, based on his smoking history, they kind of chalked it up to that. He presented to the Columbus Clinic to see me to establish care. He was admitted in an outside hospital for COPD and a CHF exacerbation, which required intubation due to hypercapnia. But he was also admitted for a similar presentation in April for the same thing, and he was intubated at that time too. And then he was admitted in February for similar presentation, but was not intubated at that time. He was discharged with duonebs without the actual nebulizer and 4 liters of oxygen, not passing judgment. So kind of further talking to him, he said he's unable to do a lot of his chores anymore. He says he's really short of breath, even walking around his house. And then when I was doing the dyspnea scales on him, he actually revealed that he was scared to even go to the mailbox because he's afraid that he might become breathless and maybe nobody's going to find him outside, which is actually one of the questions if they're afraid to do any of their activities. This was a chest x-ray that he had done about a week and a half before I saw him. This was ordered by his primary care doctor. He was also being actively treated by his cardiologist with trying to get a better regimen for his CHF. So you can see that he does have bilateral effusions, which were significantly improved since his admission or his discharge. These were his PFTs completed in the clinic. So you can see his FEV1 FVC ratio is 63, so he does have obstruction. And then his FEV1 is severely reduced at 25, so he is considered severe COPD or severe obstructive lung disease. And then the reason why he required 4 liters is not surprising because he's on his FEV1 was less than 1 and his DLCO was less than 50%. So pretty significant. This was his first ever PFDs in life. So any questions so far? Yeah, this was the first ever. No. So it's not on. So in the office, he was 99% on 4 liters at rest. He had bilateral bibasilar crackles, very mild, but he had some expiratory wheezing also. He had like 1 to 2 plus pain edema. It had evidence of venous stasis. And he was in AFib, which was his chronic condition, but normal rate. So can everybody get out your phone? Let's play some Kahoot. So you just have to go to kahoot.it and then put in this pin, and then you can like choose a name or something. And then there's like just a few questions, but at different times. 9, was it not showing up? Nine 720 719. I don't know why it's not showing up. Oh, okay, there we go. A little wheezy. Really? Okay, is everybody in? Sort of. Everybody in? Okay. You. All right, let me start. So based on what you know so far, which of the following medications or therapies would you recommend? So you have 18 seconds. So albuterol as needed, Spiriva plus Asteribors, albuterol as needed or Symbicort, albuterol plus Spiriva plus Symbicort, or send him back to cardiology for better diuretic regimen. 5 seconds. Because it's over. You have 20 seconds. All right. So the correct answer is C. And then someone picked D, which is probably kind of correct too. All right. So we will go through it. So this is sort of just an overview, and I'm going to talk about the different criteria, and then once we get to the criteria that he was at, I'll kind of go through it. But this is just a broad overview, kind of like a flow chart. But for category A, GOLD's criteria, patients are considered if they have mild and infrequent symptoms, if they have dyspnea on exertion when doing exercise or walking uphill or stairs. Their MMRC score is 0 to 1, and their CAT scale is less than 10. And they've had either none or just 1 mild exacerbation in the past year, but did not require hospitalizations. So does anybody know what the treatment would be or what you would consider for this patient? Yeah, so really any bronchodilator is recommended. You can either do a short-acting beta or muscarinic agonist or a long-acting beta or muscarinic agonist. So that's sort of like, what would you choose? What if this was your patient, if this came into your clinic, what would you do? So there's another Kahoot. And that's basically the question. So, oh. All right, so polling. What would you recommend for the patients with minimal symptoms and mild COPD? All right, so majority picked albuterol alone as needed, and then 2 people picked tiotropium. Interesting. Okay. So let's see who won. Oh no, damn it. Oh, I'm sorry. All right, we'll do this again after that. All right, so there's some, these were in chest journal, they're kind of old, in the 90s, and there's really nothing been recently done between short-acting beta agonist and short-acting muscarinic agonist, but there is some data to suggest that using a short-acting muscarinic agonist is better than using a short-acting beta, and then using them in conjunction together have even less symptoms, fewer exacerbations. And that was the study that was done in the bottom. The bottom one showed that using them together showed less exacerbations. And that's sort of the CombiVent recipe map that you can order for patients. Not a lot of people are on it. And that's because there's some newer data to suggest that using a LAMA or tiotropium in patients in early stage chronic obstructive lung disease benefit from just a LAMA alone. And that's because it reduces their hospitalizations or exacerbations and also your symptoms. This was a multi-central randomized double-blind placebo-controlled trial. It was done in China, and it had about 840 patients. And they were, the inclusion criteria, well, one of the criteria for the inclusion criteria was that they had to be GOLD classifications 1 and 2. Sorry, stage 1 or stage 2. And then the FEV1 in these patients who received the tiotropium was actually higher after, but there was no change in mortality or anything like that, but they had fewer exacerbations. Any questions? No? Okay. All right, so category B, GOLD's criteria. So patients who have moderate to severe symptoms. So their MMRC is greater than 2 or their CAT score is greater than 10. And they have increased dyspnea on exertion, stopping to catch their breath even when walking on level ground. But their exacerbations or hospitalizations has sort of stayed the same. They have had either one or nothing, and that one did not require hospitalization. So what would you guys consider for this patient? Sorry? LABA-LAMA together. So they recommend either any long-acting bronchodilator, either a LAMA or LABA, and a short-acting as needed. And you can add them together if their symptoms are persisting or if they're not, really getting better. So my question is, what would you guys just start with the LAMA alone, or would you guys do the dual therapy right away? Okay. Well, there's a Kahoot for that, but I kind of got kicked out, so we'll just forget about that. But basically the question was, would you do a LAMA or a LABA? And it looks like everyone's saying together. So this was a study done in the New England Journal of Medicine. It was a 1-year randomized, double-blinded, double dummy parallel group trial, compared 18 nanograms of tiotropium once daily, compare that to salmeterol. And there was a large study, it was like 7,000 patients were randomly assigned. And the group that had tiotropium increased, had an increase in the time of their first exacerbation by 187 days versus 145 days, with a 17% reduction in risk, and that was statistically significant. Tiotropium also had increased time to the first severe exacerbation, so something requiring hospitalization. Yes. So in this trial, it showed that tiotropium is sort of superior in patients who are moderate to severe COPD. But the only kind of thing about the study, it was funded by 2 pharmaceutical companies. One of them was Boehringer Ingelheim, which produces Spiriva. So, and this was another, it was a meta-analysis. It was a pretty large review. It included 19 randomized controlled trials and included over 28,000 patients. And this one also showed that LAMA or tiotropium significantly decreased the risk of exacerbations compared to just using a LABA alone. There was also increase in their sort of dyspnea index scores and just overall, I guess, health. And compared to the LABA had a very small but statistically significant increase in their FEV1. The difference was like 0.02. It's very small, but it is something. And this is just sort of 2 graphs that show it. For interest of time, I'm going to keep moving on. And this was another systemic review. Oh, should I continue? Oh, okay. This was an ATS. It was looked at using dual LABA and LAMA versus just a LABA or LAMA monotherapy. And this was a total of 24 studies were included in the meta-analysis, and over 45,000 patients were eventually looked at. And it showed that there was a 11% reduction in hospital admissions in patients who were on LABA and a LAMA, and also a 20% reduction in COPDs in general on the dual therapy. So superior, and it looks like everyone chose that for a reason, so good. I'm going to continue on. So GOLD's criteria, category C. So these are patients who are considered to have very mild or infrequent symptoms. They're able to perform the majority of their activities without having much dyspnea, and their MMRC score is 0 to 1, and their CAT is less than 10. But they have had at least 2 exacerbations in the past year, and at least 1 required hospitalization. Also, GOLD mentioned that this box or this criteria, not a lot of patients actually fit into it. It's usually A, B, or D. So, and in this, oh, well, that was my question, but in this category, patients are recommended to have either a single long-acting bronchodilator, either a LAMA or a LABA, but LAMA is preferred. And then you can consider adding a LABA to a LAMA if their symptoms persist. And they actually do not recommend using a LABA plus the ICS without the LAMA, just based on what we've sort of talked about. The LAMA is superior or more preferred based on the reduced risk of hospitalizations and COPD exacerbations. This was a study in the New England Journal of Medicine, which looked at a dual LABA-LAMA versus LABA and ICS. This was, I believe, in 2015. It was a multi-central trial, and it looked at using glycopyrronium and indacaterol versus fluticasone and salmeterol. It was over 3,300 patients were included into the trial, and it was a double-blinded, double-dummy, non-inferior randomized control trial over 52 weeks. And the primary outcome looked at hospitalizations, mortality, and the annual rate of exacerbations. And it showed that patients who were on the LABA and LAMA had a significant decrease in their exacerbations by 11% versus the LABA and ICS. And the annual rate of moderate or severe exacerbations was also lower in the indoceterol and glycopyrronium group. And the LABA and ICS group had significantly increased risk of pneumonias, either that required hospitalization or just sort of treatment outpatient. And that was also statistically significant. So. I'm going to continue on here. So category D, which is the last category, these are patients who have moderate or severe symptoms, increased dyspnea and exertion, their MMRC score is greater than 2, CAT is greater than 10, and they've had over 2 exacerbations in the past year, 1 at least requiring hospitalization. So what would you consider for the patient in this category? Triple therapy, yep. So a LABA, a LAMA, and a short-acting as needed. And then if they've continued to have further exacerbations, you can add an inhaled corticosteroid. And then if that doesn't work, we're going to talk about it, but sort of refractory treatment. Triple therapy is associated with fewer exacerbations, fewer hospitalizations, but you do have an increased risk of pneumonias. And withdrawing an inhaled corticosteroid after they've been on it for at least a year or a few months does not increase your risk of exacerbations. And there's a trial that I'm going to talk about, but it does decrease your FEV1 slightly. So these are some ATS recommendations, so separate from the GOLD. They recommend a combination of LABA and a LAMA therapy over monotherapy. This is a strong recommendation with moderate evidence, and we've kind of discussed this already. Triple therapy is recommended over a dual therapy in patients who've had 1 or more hospitalizations for COPD. And this is a conditional recommendation, mainly because if they have increased risk of pneumonia, then you probably don't want to put them on that. And then they also recommend that if they they're on a triple therapy and they haven't had a exacerbation in the past 1 year, then consider removing the inhaled corticosteroid. So this was the trial I was talking about. So this is the Wisdom trial. And it was done in 2014, and it looked at the withdrawal of inhaled steroids in patients who have COPD and sort of the risk of further exacerbation. So this study looked at over 2,400 patients with severe or very severe COPD receiving triple therapy, so a LAMA, LABA, and inhaled corticosteroid. And this was sort of looked at over a 12-week period. And among the patients who had severe COPD receiving triple therapy, tapering the inhaled corticosteroid after they did not have further exacerbations was not associated with an increased risk of exacerbations. So it's very appropriate to taper down medications or step down medications, especially if they have an increased risk for pneumonia or if they keep developing pneumonia. Yeah. I'm going to get to that. Yeah. So the question was about eosinophils, and I'm going to get to that just in a couple of slides. And then withdrawal of an inhaled corticosteroid was associated with a modest decrease in the absolute FEV1. It wasn't even that statistically significant. 38 versus 43. So we're not doing Kahoot now. So can anybody name some medications that can be used for refractory COPD after they've been on triple therapy and they continue to have either exacerbations or. Yep. So one of the medications you can use a PDE3/4 inhibitor, roflumilast or Daliresp. You usually do this 250 milligrams daily for 4 weeks, and then you increase to 500 milligram. The results have shown, I'm going to talk about the trial that was done. It's a REACT trial, but it shows the results are very modest, but it does show a reduction in exacerbations and hospitalizations. But patients often have GI side effects, which actually cause them to stop the medication, pretty severe diarrhea and things like that. This is a second-line agent. It's a very expensive medication, so that's also a limiting factor for a lot of patients. And then, of course, the side effects we talked about. But this was the REACT trial, and it was published in Lancet in 2015, I believe. And it was a multi-center randomized controlled trial, which did show that there was a small improvement in FEV1 and reduced exacerbations, no change in mortality, which I want to point out that everything we talked about, all the inhaler therapy really has not shown any changes in mortality. And then the other medication we often use, because it's a little bit more cheaper, is Zythomycin. You can do this 250 milligrams 3 times a week. And it's used in patients with refractory COPD. They have anti-inflammatory effects with the macrolides, which we know about. The only thing you need to watch for is QTc prolongation and also hearing, because it's ototoxic. So there has not been a study that's kind of looks at which one is better, which is Zythomycin versus roflumilast. But there's an ongoing trial right now. It's called the Reliance trial, which is a multi-central trial, and Henry Ford is one of the centers that is involved in it. And it's a randomized trial, which is comparing the effectiveness of roflumilast versus azithromycin. And the primary endpoint that they're looking at is the combined outcome of all-cause hospitalization or death. And some secondary endpoints they're looking at are premature treatment discontinuation, mainly due to the side effects we talked about, patient-reported adverse effects, and physical, social, and emotional health. Some time. So I'll talk about the inclusion criteria. This is also on the HFH PALM website if you have a patient that feel that you could be in this trial. But it's the inclusion criteria is that patient and treating clinician are considering treatment intensification with either roflumilast or Zythomycin because they are on triple therapy and they're still having symptoms or exacerbations. They have to be 40 or older, current or past smoker of at least 10 years. They have to carry a diagnosis of severe COPD and associated chronic bronchitis. They have to be hospitalized and with a diagnosis of COPD exacerbation in the past 12 months at least. And they have to be on inhaled LAMA, ICS plus LABA, or at least a LAMA and a LABA. They don't have to be on an ICS if they have some sort of contraindication. English or Spanish speaking, and they're willing to provide a contact telephone number. So steroids the chronic use of oral steroids are actually not recommended. It actually does show an increase in mortality and morbidity in patients with COPD. And then they have a plethora of side effects that we know about: weight gain, osteonecrosis, bone loss, all that kind of stuff. We do see patients on it sometimes, unfortunately, but it's not shown to reduce their exacerbations. It's not shown to sort of even improve their life. So I'm going to quickly touch upon eosinophilia and COPD. So there is a subset of patients who, despite being on triple therapy, sometimes have worsening symptoms, and it's we should take a look at their eosinophil counts if there is some evidence that they're having exacerbations based on that. There are a number of studies that suggest that patients who have eosinophilic counts of over 300 should be on inhaled corticosteroid therapy to whatever they're on before. There's really no benefits with counts less than 100, and actually increases their risk of pneumonia if they are on less than 100. There's a current trial, there's a post hoc analysis done from the Wisdom trial I was talking about, which showed that withdrawing inhaled glucocorticoids in patients who have eosinophilic counts more than 300 can be associated with an exacerbation in their COPD. So in most patients, you don't see an risk of exacerbation, but patients who have underlying eosinophilia, they will have that. And then once again, Henry Ford is part of a study. It's called the Sanofi dupilumab trial. And we're investigating the efficacy and safety of dupilumab over 1 year in patients with COPD and eosinophilia. It's multinational randomized control trial in phase 3. And kind of time to go over the inclusion criteria. So they have to be between 40 and 80 years old. They have to have a more than 10-pack year smoking history or currently smoking. Triple therapy for at least 3 months, but if they do have a contraindication to inhale corticosteroids, then they don't have to be on that. Their FEV1 FVC ratio has to be less than 70%, and they have to have an FEV1 of over 30%. So they can't be in a very severe COPD. And they have to have at least one severe exacerbation in the past year, which required hospitalization, or 2 moderate, which didn't have to have exacerbation, but you put them on steroids and or antibiotics. So some non-pharmacological therapies, pulmonary rehab, everyone should be considered for pulmonary rehab. It's a very good option for most people, especially if they live in certain areas that have it. And then lung volume reduction surgery, if they do qualify for it, especially upper lobe predominant emphysema. I'm not going to go too much of it because we already had a talk on that. And then I always like to sort of put this in here. So a lot of our patients come in with COPD exacerbation. We talk about non-compliance and non-adherence. And a lot of our patients are not insured. So these are just some of the prices that pharmacies helped me with, and I saw online how much it would have cost for some of these inhalers if they did not have any insurance. So if you wanted Spiriva, which we talked about using a llama, it's $500 for a 30-day supply, which is like insane. And then compared to other countries which are cheaper, so I like to use of Canada because I'm Canadian. The Spiriva is like a fraction of that cost. If you don't have insurance, probably less than $100. The Pro Air, I used to pay $20 in Canada with the insurance, and without insurance in the United States, it's $80. So it's a big difference. And then there are some websites that you can send your patients to. They're like Canadian online pharmacies that you can prescribe to, and they get it delivered for the Canadian price. So always a good option if they're coming in because they are unable to afford it. So thank you to Dr. Ouellette for all your help. And any questions or comments? What? Transplant? Oh, right, yeah. Anyone in the chat? No one in the chat. Great. All right, thank you.